I'm Fartun Weli.
My name is Anna Levine.
We're talking about the health piece, and it's so big. And those of you who are from college, those who are you thinking about everything else, health is so big that based on the social determinants of health is the environment, economics, health, and what else am I missing? So many things. Social connectedness. And I'd love to talk about health, mainly public health, preventative health care. Anne and I have something in common. She still works at Park Nicolet Health Services. That is where I started working when I didn't even speak English, but I knew how to really get a vein. I could just find a vein, my eyes closed, because I started volunteering at a young age in Somalia during the cholera epidemic. My sister was a nurse, so I ended up there. I was supposed to be a doctor, but it didn't work. I hate math, so don't tell that to the kids. But I became, I think, better by being a public health professional. And so she works at Park Nicolet. She'll talk about herself. But I love about health and women's health access because it's not only important for the family, but it's also being well-being. It's so critical. And giving you a data, Minnesota has, as Huda talked about, the health disparity of Black and brown women and Native is very high. And preventative care access is also very low. And it's no-brainer because there are no many communities of color providers or culturally specific services. Because when this system was created, it wasn't really for Black and brown women. Black and brown women they weren't part of to making healthy. Then the whole America was kind of weird. So right now, there are a lot of culture changes happening. We're talking about disparities. We're talking about inequality. Today, we want to talk about when it comes down to actually going to the doctor and getting access. So introduce yourself more than you, Anne. Go ahead.
I'm Anna.
Anna. Sorry.
It's okay. I have been at Park Nicolet. I'm a nurse midwife, which is a master's prepared nursing degree, and we only deliver in hospitals. I will not come to your home and deliver. You do not have to, what I always say to people, you don't have to want to eat your placenta or any of that stuff. We are mainstream medical providers. Minnesota has a quite robust midwifery program. We do have home birth midwives, but I have always wanted to be in the hospital for a couple different reasons. I've been at Park Nicolet for 13 years. It's been my only job in midwifery, so I do live in a bubble, and I know how we provide care. I hear from women from other establishments. Obviously, other establishments hear about women from our establishment. But I feel very proud to be at Park Nicolet in my department, in my midwifery group and my OB group. But our midwifery group is very, very close, very solid. We practice very similarly. And a huge passion of ours is taking care of our immigrant population as well as all women. Midwifery in the United States started from midwives coming from England to take care of the women in Appalachia that had no access to health care. So if you look that up, you see women riding horses up in Appalachia with babies in their saddlebags. We don't do that either here. We actually drive cars to the hospital. And I actually thought we were talking more about immigrant healthcare, which I think ties into healthcare and health disparities, which is huge. I just am definitely not an expert on either, but know that work it's all about kind of heart and soul. Like there's other stuff you have to deal with, like charting and IT and politics, but that's not why I'm in it.
So immigrant health is important, and we're going to talk about it, but also we want to acknowledge the Native and African American women who have been here before us and are an example of, I tell people, immigrants aren't important because there have been a community here in USA that are still struggling. So the sense of urgency why ISURON exists is to make sure that we're not becoming part of the data of disparity, but how do we learn from what is happening to African American and Native women in terms of access? And you serve many Somali families, especially women with specific reproductive health challenges, such as female genital cutting. And do you want to talk about the challenges that women face? We know many cultures, they're not preventative care. It's all about, I want to go see a doctor when I'm really dying, or I'm going to have a baby soon, but she hasn't seen a doctor. But how what you're doing in terms of serving immigrants have been both challenging and also rewarding?
Well, I think even though I haven't been practicing that long, in the time that I've been practicing, I've seen a huge change. Second generation, third generation women coming in. And so it's very different, right? But with the new immigrant, which I had to learn kind of on the fly, which is another thing I'd like to talk about, is trauma-informed care and our healthcare system not being trained in that, which I think is abhorrent. And necessary and needed to be able to take care of women wholly. It's simple things like I work with my interpreters and they're always like, oh, that's a good point. I'm like, have you ever been to a hospital in America? It is very different. Let's go take a tour. Can we do a tour in your language? This is what it looks like, because I can only imagine the anxiety of, I mean, I can't even imagine because I've never been there. That would feel like, and having a baby is such a vulnerable and important piece. You want to feel safe, and you can't do that if you have no idea where you've been, you have no idea who your advocates are. And I think there's a lot of stories, obviously, of good healthcare, bad healthcare. So that is just a really simple way of getting women to feel comfortable and welcome and part of the system and part of our team. I always tell patients, once you're cared for us, we're one of your sisters, and you may not like us every day. It's like you don't like all your sisters every day of the week, but we're family and we're going to be taking care of you.
So we did a research with San Francisco University and interviewed Somali refugee women, and we asked their experience on having baby in a refugee camp or somewhere in Somalia or Ethiopia, wherever the refugee camps, and at least have a child here in the USA. And one of the most critical they talked about was how some of them were in labor 48 hours, 3 days, how many of their other sisters did not make, because East Africa has highest infant and maternal mortality due to lack of health care, poverty, and mainly bleeding. And if she has female genital cutting, it's a high risk also added. But one of the complaints about labor and delivery they talked about was how women, and again, it's the high rate of C-section and how they don't trust the healthcare system, is that how it was easy for, say, a white provider would make a decision in a woman and say, let's have you do C-section. So they talked about the difference where back home, even though it was very hard and lack of healthcare, but they said women had the opportunity to go into labor and either give up or have at least enough labor time. But here in the USA, they said, you go in, and a few hours later, they say, oh, the baby's heart is down, let's take you to the C-section. And the C-section, even though it's a life-saving medical care, which is absolutely is needed, many of them had interpreted that based on that they did not want to deal with the female genital cutting. That is one. And then also they thought there was a racism. So how do you deal with that kind of a belief that many women, to ours with the female genital cutting and being an immigrant, but also a black woman and Native woman who may have also the same attitude about the healthcare system?
Yeah, so a couple things. As I said before, I have worked in a bubble, right, at Park Nicollet. I know how we practice. I know how my partners practice. But I know this exists. I'm not so naive that I know this doesn't exist. But in being a new midwife, coming in in having patients decline a C-section when you're watching fetal distress, which is the information we have, right? Not that it's a perfect system, but watching literally and hours go by and declining a cesarean. And it's not unique to the Somali culture. There's other immigrant cultures that are very distrustful, which I think is important. But declining and not having that trust has been a huge learning experience and barrier for care. I think it's changed quite a bit in the 13 years I've been here. You know, that the perception was we're doing C-sections because the docs make more money. And once I think we convince or show the data or show and just take care of our women respectfully, I haven't seen that. We see it, but we haven't seen it as much. It used to happen quite often, which I'm very happy about, at least in my experience and at my hospital. So, and then, you know, how Fartun and I have gotten to be close in talking was caring for women with FGC, which, and I don't want to use adjectives that aren't proper, but for me, the cool thing to see now is we don't see them that often, right? Because there's OMG. But the generations have changed, education. So I don't see them that much anymore. I mean, we definitely see them, but the really, you know, significant ones, I don't see that often. We've set up quite a good system of trying to talk about them at new OBs. So there's an option to discuss if there needs to be surgical revision before. There was, I think, years ago, a big discussion about repairs after delivery, and the last conversation we had about this was many doctors were refusing to repair, and what were the implications of that?
So with that, and I will open questions. One of I became a doula 3 times, and one of the last labor and delivery I was in, the woman was in labor 8 hours. We went to the hospital about 7 p.m. and then 3 a.m. a Somali nurse was working with us, and the baby's heart rate was, again, keep dropping, and then they were shifting her, change here, do this, do that. And this is the 5th baby for that young mom, like hardcore. I've never seen a brave person ever. And then her and I, as she was doing this, I was talking to the nurse, and what are the chances that, you know, this, I was saying I don't want to lose her. And she looked at me and she said, if you're thinking about C-section, I'm ready, I'm tired, I want to do it. And somehow, she was also asking the epidural, the pain, you know, it's like, I can't handle the pain, but the labor was so fast that the nurse didn't have a space to even give the epidural. She said, this is too dangerous. Her uterus is already like on fire. Lo and behold, 5 a.m., the baby's head just came out, but it would not budge, just stuck there. This doctor came in, and I kid you not, she was fighting 2 hours to free that boy, and just 7 or 6:30, the baby just came out. And within a second, this young mom who had a female genital cutting, 5 of us were there trying to save this mom and this baby, and then the provider just walked away after the baby came out. And I was like, where are you going? And she's like, I'm done. I say, you're not done. You're fixing this woman's private part because she just went through hell. Well, I'm not doing it. It's illegal, she said. Imagine. Then the woman said, I don't want any repair. I am done. But what happens, too many women who have had female genital cutting go through hell and have the baby, and many providers leave it unrepaired. Then what happens, then that woman, after she finishes her postpartum, there's so many adhesions, so many things go down there that they have a higher infection rate. They also have very insecure about themselves. So it was in a split second that humanity that the provider was saving this woman's life, it became a white feminist behavior. She switched. And, she became from being so human and so all of a sudden judging. We fought right there. I said, you're not leaving there. So she fixed it, and really, she looked at me and said, this is crazy woman. But I wasn't. I was like, you cannot leave this woman that way. After she fixed, she said, I'm sorry, this was my moment of tiredness and this and that. So there's many, many, many changes are happening, not only Park Nicola, but I think there's so many good news that are happening around. Providers are learning how to serve better. How do you maintain relationship? I know your schedule is packed. I know my provider schedule is packed. What are you doing to really create that relationship where women are keep coming back to you guys? Especially you're famous.
I don't think that's true. I want to say one thing, though. I think the importance is with education, and this is for any woman, but especially in this circumstance, we could have avoided that completely by educating women, advocating for women to speak up, but we have to have that conversation in the beginning before you're in a moment of trauma. And anybody in their right mind wouldn't want to be touched any longer. If you've had a baby, when the baby comes out, you're done. Like, I'm done and I'm done. Whether you need something more or not. So having that conversation ahead of time. I talked to one of my physicians who's very good friends with Fartun, who couldn't be here today. And I said, what do you think they're actually getting at? Like, what do you think Fartun is actually getting at that is the big controversy? And one thing she said that I think is the huge miseducation and misnomer on our part as providers, white women, non-African women, is thinking that we're doing something, we're contributing to something that we find is harmful, which we could have a whole conversation on that piece alone. But as a medical provider, she said, I think what people are misunderstanding is that, there's different types of FGC, right? But the complete infibulation and after a delivery to put that back together, whereas a medical provider, that may prevent or may create more health problems in the future, right? And a really easy fix for that is having a conversation beforehand, right? And it really should never be a legal issue, and it shouldn't be this is my belief, this is your belief. That has nothing to do with healthcare, in my view. So that was one important piece, which I thought was really interesting. Later if they needed surgery or they needed just a Foley catheter and we couldn't get to the parts that we needed, I think that's where people think when you're asking to be reapproximated or something, the uneducated piece from the provider is that's what they're asking for. So I thought that was a really interesting point.
Deb Thorpe knows that. So, but again, it's really also patients' rights. And if the provider, mainly what our African women with female genital cutting really talk about is not the lack of understanding, it's how female genital cutting, they thought is about women, oppression women, and it comes from Islam and this and that. So it's this it's like a feminism kind of activism that they talk about, but the lack of understanding, or if the idea was I'm not going to reconstruct because I need to get to your, whatever I need to do, and patients being educated, but what they usually do is they're saying really, this is, it was women's, violation, something being done. They talk about the activism aspect of it, and the healthcare aspect of it goes away.
But by not listening to the woman is actually anti-feminism. We're not going to define feminism.
Well, but that is hopefully we can talk about what feminism and what that is. But then for you guys, as you're saving lives but I know that your institution is changing a lot and have changed a lot. Talk about quickly about how are you engaging diverse workforce. We have a lot of young college goers, and what are you guys doing to maintain?
Well, sadly, I don't feel like I'm going out and engaging, but it just is happening, which is amazing. You know, we have, for Minnesota, a somewhat diverse workforce. But we have, you know, Somali nurses, and I have a Somali midwifery student. I have 2 nurses that graduated midwifery school last year. And I just think that I've learned from these women, you need to be cared for women that look like you and are from you. And I think that's important, and I can only do a piece, and people can recognize compassion and honesty and genuine care, but I think it's very different being cared for women that look like you and trust. And I've learned that from the speaker that was supposed to be here. Spoke about that at a conference about that's such an important piece in healthcare that we're missing, is because then there's trust from a community or a community member and being cared for by your people.
I want to acknowledge that the healthcare industry in Minnesota has the largest African nurses from Liberia and Nigeria. And I think Somalis may catch up or may never catch up, but that healthcare industry in Minnesota is really, they're getting African nurses and also African American. We want to open a few questions to the audience. Yes?
I was just wondering about, like, in terms of being able to, like, in terms of cultural competency and stuff like that, in what ways do you think that you engage? I don't know if I missed that question, but, like, one thing I did want to point out is, like, saying midwifery started from, like, an English foundation or something like that, because I would, like, challenge it and say, like, slaves probably had midwives.
Totally.
You know, and probably
Absolutely.
Totally.
And I think that in my education, I've gone like along with like listening to all of the things that I heard and believing them, and then it's like always that like white people are the one inventing things, white people are
And you're totally right, and that was
She
a
didn't mean that.
misspeak. It was, I think, in my education, learning about maybe setting up midwifery school, I should say that. And, you know, learning about granny midwives was like an aha moment. And I know in other countries, midwives rule, like they're all about healthcare. So you're absolutely right.
Thank you. Yes?
One or two maybe empowering or things to say in a moment of trying to assist someone related to consent, because I know that we were talking about
FGC.
but for consent in general in healthcare, me saying to someone, excuse my touch and touching them is not true consent, or I'm going to place this is not true consent. But in the American healthcare system, we think that that's enough, whereas someone may not want to go to that next level of care or receive good treatment. So what would be one way that you can think of to help empower individuals in that moment of decision to know, okay, am I really okay with this, or is it warranted more questions to be asked?
So the question was, those who couldn't hear, how do you empower someone about consent, whether they want to say yes or no, right? Did I say that? So it's absolutely, when someone is in pain or before they get to the doctor, that's the health literacy piece. And also, at least I can speak as an immigrant, where providers, especially doctors, military, and teachers, are high rank of authority. And those authorities are trusted. My mother trusts them, my grandparents, my whole clan trusts that person. So even if they give us bad advice or nothing, we trust them and we take it. So then that's why we don't have a written consent, it's a trust. So then when immigrants come here, this is what's lost, is that trust. So an interpreter gives them and says, sign here, they'll just sign. They don't really know what they're signing. So this is why our organization does health literacy, system literacy. It's really training everyone as they don't know what they're doing. But also telling the providers, like for instance, medication is being written. Some of the elders will take the medication and trash it. She won't say, I'm not going to take this medication because this person, it's not like because the person is black or white, it's just they are in that authority mode. And so, long story short, and I will let Anna speak, Anna, speak, and that's for us is health literacy. It's on the health literacy from the get-go, and saying you have rights, and also the other thing we talk about privacy. Even if we have interpreters from the community, confidentiality has to be told this patient over and over and over that their information is private.
I'd have to think about a specific question. I know there's a million and I can't think of it, but I can tell you as a provider what I think is important. And the cool thing about midwives in their core, and I can't say all midwives practice like this, is education and being a part of the hierarchical, if that's a word, medical system, right? It's no wonder we have low rates of annual health care, primary health care. There's a long history of distrust, which is deserved. But back to, getting care by people that look like you, being told usually by a white man, this is what you should do, not, do you have questions? What's your history of this? What is your family's experience? I would imagine that is created and going to be very hard to break a system of distrust. So I can tell you what I do before any exam, if they've agreed to an exam. Have you been traumatized? What's your history? Do you have a history of assault? There's a little piece I want to add on to that, but so many women look at me and they're like, I've had 1 million pap smears and no one's ever asked me that. Well, why wouldn't you? This is a crazy, vulnerable, and possibly triggering event. And I always want to give you the option. It's not an emergency life-saving procedure, right? If you're coming in with pelvic pain, I need to explain to you why I want to do a pelvic exam and why it may not be necessary. But you come in for a routine exam, you've never met me, you're 16 or you're new to the country, I don't need to do that. Like, why are we doing all this standardized care? Let's actually individualize care, earn their trust, and then when they actually have a problem, they're okay with an exam, right? And you should always ask. So how do you turn that around for the patient to advocate for themselves, I think is hard, and I have to think about it. And I know as a patient, I've been in situations where I have not advocated for myself. I'm like, I am 44 years old, I am a provider, it is 2020, and I did not just advocate for myself. So I think that's really hard.
It's a journey we need all to do. Another question? Yes, then Dr. Antonia.
Could you please comment on the whole, the role of doulas in
Yes.
this environment?
You talk about it. Hi, Dad.
Who knows about doulas and what the difference is between a doula and a midwife and a doctor, an OB? Does anyone want to contribute?
Is the doula more about like coaching?
Sure.
Supporting companion, but she's not degree
Yeah.
like a midwife,
Right.
nurse midwife.
Right.
Is
Which I do
that's
want to.
very important in disparities reduction.
It's true. So doulas are, I always say, your biggest cheerleader, sometimes your translator, even English to English, right? And someone to help navigate through your experience. I think super important for single moms, new immigrants, not non-English speaking patients, I think are super huge. So they know they have someone there constantly on their side. Your nurse doesn't speak your language probably, maybe. They're your advocate, but they may have other patients. I'm not always there. I'm definitely your advocate, but I may have 3 other patients in labor. So a doula is amazing. I think research has shown better outcomes, better satisfaction, and when you engage in childbirth education or a relationship with a doula antenatally while you're pregnant, longer birth time, birth gestation. So can we change this disparity of African American babies being born too early and low birth weight? And then postpartum, changing postpartum health care, postpartum depression and lactation. So they're huge.
Thank you.
With that said, doulas are the best. And everybody can be a doula, but especially those of you who are starting in a public health or a nursing, everybody can become a doula. Quickly, what I want to say, we're out of time. A student have been funded by Bush Innovation Grant, and we're starting to develop the new initiative that will be working on specifically women and girls with female genital cutting. And stay tuned. We would really want to focus. More of the focus have been, oh, this is Islamic thingy, women are oppressed, and never the quality care of the women and girls that have gone through this procedure. And we want to make sure that they're not only being judged, but they're celebrated, because we can never prevent female genital cutting, at least outside in USA, unless those who have gone through have the right to get better procedures, better processes, and trained providers. And so with that said, we're out of time.
I want to say one more thing.
Go ahead.
So I was thinking all morning, because I thought we were talking specifically about FGC. I was like, ugh, what do I talk about? And trauma-informed care is huge, but I also, a fellow physician and I do a vulvar clinic that specializes in vulvar health care. So seeing the disparity in vaginitis in women, especially African-American women, is huge and become a very popular topic on social media recently with a new product that's come out. So if anybody wants to talk about that, I'd love to afterwards. But vulvar healthcare and yeah.
What's that?
Well, so the vulva, right?
I know that. What do you do with it? Around, you can come.
There's a great quote in a New York Times article that a physician mentioned is, the vulva is like a small Midwest town that you just drive right past through. Yeah. You don't even notice it. So,
I couldn't help it.
It's, what do you do?
Okay. Sorry.
There's lots of jokes in my field. So it's specializing in, there's a lot of dermatologic issues with vulvar cancer, and I actually got pulled into this clinic and specialize in vaginal infections and talking about the vaginal microbiome. So
that's fine. We had to mention that space before
I
day ended.
I had to go there.
Could you please give a round of applause to Anne? And she'll be available for questions. Thank you so much.